Hello, and welcome to today's webinar. My name is Jessica Moss, and I'm the Director of Physician Marketing at Agendia. This webinar represents the third in a series of educational webinars. Thank you for joining us today's event, and we hope you will join us for future events as well. I'd like to introduce today's presenter, Dr. Pellicane. Dr. Pellicane received his undergraduate degree from Johns Hopkins University and his medical degree from the University of Pittsburgh School of Medicine. He completed his general surgery residency at Virginia Commonwealth University and is board certified by the American Board of Surgery. He co-founded the Virginia Breast Center in 2005 and affiliated with Bon Secours in 2008, now with 3 surgeons serving all 4 Bon Secours hospitals in Richmond. Dr. Pellicane currently is Director of Breast Oncology at the Bon Secours Cancer Institute in Richmond, Virginia. Note that a recorded version of this webinar will be available after the presentation. Thank you to everyone who submitted questions during registration. All questions will be addressed at the end of the presentation. However, please also submit questions live. We would love to hear from you. For those of you just joining us, welcome. We have Dr. Pellicane here with us and are looking forward to his presentation. Off to you, Dr. Pellicane.
Thank you, Jessica. I appreciate that, and I appreciate the opportunity to present this data tonight and to present some provocative data and generate some discussion about the use of genomics in neoadjuvant chemotherapy. We'll get right into it. The first thing I'd like to talk about is just a little bit about MammaPrint and the development of the MammaPrint assay. Now, some of you may have heard this already, and if you have, I apologize. Others, if you haven't, I'm going to explain a little bit about the development of the test. The test was discovered back at the Netherlands Cancer Institute when there were patients who had breast cancer and frozen tumor samples. All these patients were untreated with no adjuvant therapy, and so there were frozen tumor samples and outcomes on patients on untreated patients. In the low-risk group, you see at the top of the screen, these are patients who did not have a distant metastases within 5 years, and the high-risk group were those that did have a distant metastases within 5 years. The entire human genome was run on these patients, starting with about 20 to 25,000 genes, and then they were force-ranked in order of importance to come up with the 70 genes that were most predictive of risk of recurrence when the recurrence was identified, and that's what commercially is available today as Agendia's MammaPrint. MammaPrint is sophisticated enough to really interrogate 7 genomic pathways of the metastatic cascade, those of which you can see here. As you all know, the biology of metastases is very complex, and many things have to happen in order for metastatic disease to develop. And again, MammaPrint is sophisticated enough to figure that out, which is why you end up with a binary test with just a high-risk and low-risk group. And this is the heat map of the test itself. You can see the high risk looking different than the low risk on the top. And the important point in this slide I really want to point out is the MammaPrint index on the right. This is going to come into play a little bit later in the talk when we talk about neoadjuvant chemotherapy and the importance of looking at MammaPrint index, which really represents just a ranking of the high risk to low risk, so -1 to the highest of the high risk up to +1 of the lowest of the low risk. This is a slide of the first independent validation study done on MammaPrint several years ago. These are all in untreated patients with 10-year outcomes, and you can see that the high-risk MammaPrint group in the red has about a 29% chance of recurrence at 10 years. This is distant recurrence. In the low-risk group, about a 10% chance of recurrence at 10 years. And I want to show this slide to talk a little bit briefly about predictiveness. When we look at the recent results in the MINDAC trial, these results are from the concordant group in MINDAC. So these are clinically low risk and genomically low risk patients who are treated with endocrine therapy, and clinically high risk and genomically high risk patients who are treated with chemotherapy and endocrine therapy when appropriate. And you can see how the outcomes are different. And when you overlay these outcomes of treated patients with untreated patients, you can see that not only is MammaPrint predictive for chemotherapy benefit in the high-risk group, but really predictive for endocrine therapy benefit in the low-risk group with a survival rate or a distant metastatic free survival rate of 97.6 in the endocrine therapy treated low risk and 90.6 in the chemotherapy treated high risk. So looking at this data, the question then becomes, is this data going to be useful in the administration of neoadjuvant chemotherapy, and will it be helpful in choosing patients who would benefit from neoadjuvant chemotherapy? And so one of the aspects of Agendia's testing is something called Blueprint. And what Blueprint is a look at molecular subtyping. This slide is Chuck Peru's slide, where he originally described intrinsic molecular subtypes for invasive ductal carcinoma, and you can see that you barely see the graphs at the bottom, but get an idea for the difference in outcomes based on subtype. And so what Agendia has been able to do is develop a functional molecular subtyping that has will split these tumors into three classes: luminal, HER2, and basal. And this is just a brief slide on the development, which I won't go into in detail, but suffice it to say, when looking at ER, PR, and HER2, they were looking for concordance between IHC and FISH testing and single gene expression of messenger RNA. And when they got concordance, they then further studied these samples and came up with three molecular subtypes: luminal, HER2 dominant, and basal. When you look at functional genomic profiling of breast cancer with MammaPrint and Blueprint, what MammaPrint adds to Blueprint is risk stratification. So in other words, you look at a luminal subtype patient, and if they have a low-risk MammaPrint, they're luminal A, and if they have a high-risk MammaPrint, they're luminal B. And even the HER2s will break out into high risk and low risk, mostly high risk, but there are some low risk HER2 dominant subtypes, as well as a very small segment of low risk basal subtypes. And again, MammaPrint points out the potential for distant metastases in the first 5 years. High risk obviously higher at about 30% and low risk at about 10%. And Blueprint really showing which pathways are active and which pathways are dominant, driving the metastatic cascade. So what exactly are functional molecular subtypes? Molecular subtypes are utilized to show which pathway drives the cancer growth, whether it be the luminal pathway, which is driven by estrogen, whether it be the HER2 type or HER2 dominant subtype, which is driven by the HER2 pathways, or whether it's a basal subtype, which reveals really neither pathway being active or dominant. And what you'll see, or what you'll hear certainly in talks and written in papers or even in tumor boards, is people talk about luminal A's, luminal B's, HER2s, and basals by doing what we consider clinical subtyping. In clinical subtyping, where you try to figure out a luminal A from a luminal B based on the presence or absence of a progesterone receptor or on the level of Ki67, when you look at that type of subtyping compared to true molecular subtyping, what you find is a discordance of about 20%. So when you try to subtype clinically, by using IHC, you'll be wrong about 20% of the time when you compare it to functional molecular subtypes with Blueprint, and that data is consistent with Peru's data looking at intrinsic molecular subtypes as well. So again, what is the difference between clinical subtyping and molecular subtyping? When you look at protein expression and you take the estrogen receptor, for example, there are really three ways to measure the estrogen receptor activity. One way is to look at messenger RNA and single gene expression. The other way is to look at IHC, which really tells you the absence or the presence of the protein receptor on the cell surface. And then the third way is to look at the estrogen receptor function with Blueprint, which really gives you an idea of whether or not that estrogen pathway is active. As you know, the estrogen receptor gets bound, it gets taken intracellular, and then activates a complex pathway of the estrogen receptor, or of the estrogen pathway. If one of those genes is not functional, as is illustrated on this cartoon, then the whole pathway fails to function. And what you have is a cell that has the estrogen receptor present, but the pathway is not active. And this is the benefit of looking at Blueprint and looking at particular pathways involved in breast cancer metastases. And this is really one explanation for why when you clinically subtype patients, you look at an estrogen receptor positive patient, and some of them respond to therapy, but you always have some that will not respond to anti-estrogen therapy. And the question really becomes why. And it generally speaking is because that estrogen pathway is not active. So again, clinical subtypes will show the presence or absence of protein expression in tumor tissue, will show the presence or absence of the estrogen receptor, but molecular subtypes will show which pathway is actually driving the cancer and which pathway is dominant, even though two pathways might be active at once. And I'll explain what I mean by that in a little bit when we go through some data from the NBreast trial. Blueprint will identify luminal types, HER2 dominant types, and basal subtypes. And in combination with MammaPrint, will give you a risk assessment of those subtypes. So how can this be applied in the neoadjuvant setting, and can true molecular subtyping actually be helpful in choosing patients who might have a PCR, a complete pathologic response? So just to review, and I'm sure all of us have the same ideas about who we choose to treat with neoadjuvant chemotherapy. If you look for what I would call the old school, or the reasons we used to do neoadjuvant chemotherapy, it was really for patients that presented with inoperable tumors. There was really no other option for them, excuse me, except to give them chemotherapy to try to make them operable. And they could be operable but have a locally or regionally advanced tumor, which would make their surgery more difficult. Also, a little bit later, but still really kind of in the old school thought process, is to take a patient who would need a mastectomy based on their size of their tumor compared to their breast size and change them into a breast conserving surgery candidate by shrinking the tumor preoperatively with chemotherapy. And really this has progressed now to look at, really consider any patient who we know needs chemotherapy, consider them for neoadjuvant chemotherapy. And can we base it on genomics to give us a better idea of who's going to respond and who isn't? So of course the history of neoadjuvant chemotherapy is initially for inoperable tumors, evolved to increase the number of breast conserving therapy patients that we could do in patients that had larger tumors or moderate sized tumors and smaller breasts. And now really in some markets it's being used for any patients who need chemotherapy. It really acts as more or less an in vivo test for chemotherapy response. And what do we know? Well, we can certainly know we can downstage patients and make breast conservation possible in those who otherwise it would not have been. It does not improve overall survival from what we can tell now, but again, you have to look back at why we used to do neoadjuvant chemotherapy. And the question is there a group or groups of patients as we study them longer going forward that actually will have an improved outcome with regards to neoadjuvant chemotherapy? We also know that in certain subtypes, specifically basal and HER2 dominant subtypes, that a complete pathologic response can be prognostic for good outcomes in that group. And the other thing is it avoids any potential chemotherapy delays. And we know there's good data now to suggest that if your chemotherapy gets delayed for a certain number of weeks, and that can be as low as 8 weeks after surgery, that those patients may have a worse outcome. And the reality is, in those patients, we start the clock at surgery, but does the clock really start at diagnosis? And so my feeling on patients with neoadjuvant chemotherapy is it really avoids any potential chemotherapy delays. If you have a high-risk basal patient or a HER2 dominant patient that you know is going to need chemotherapy, why not get their chemotherapy started, avoid any potential wound complication delays or surgical delays that would in essence delay their ultimate chemotherapy. And then what we also know is that some subtypes do not respond as well as others. Even though we know they're going to need chemotherapy, sometimes it might be prudent to go to surgery first in certain subtypes of breast cancer. So can genomics help predict a PCR in patients receiving neoadjuvant chemotherapy? Well, present this to you. This is some NBreast data as well. And what this does, it looks at MammaPrint index and graphs it against the probability of a complete pathologic response. And in this graph, you can see the MammaPrint index is graphed along the bottom. All the way to the right is +1 or the lowest of the low risk, and it moves to the left towards -1 or the highest of the high risk. And you can see that mammaprint index really is positively associated with the likelihood of a PCR. The red circles are patients who have had a PCR. The gray circles are ones that did not. And you can see as the patients get more towards the low risk part of the mammaprint index, they're less likely to have a complete pathologic response. What about functional molecular subtypes on neoadjuvant breast cancer therapy, and how are they useful? Well, several years ago we published a paper out of the NBreast trial, and for those of you that aren't familiar with NBreast, it was a neoadjuvant registry trial where we looked at mammaprint and blueprint preoperatively in patients who are clinically high risk and requiring neoadjuvant chemotherapy, and looked at PCR rates in that population and compared it to molecular subtypes and to mammaprint risk. And what we found was some fairly interesting things. So first, in these clinically high-risk patients who were luminal A's, who got neoadjuvant chemotherapy because they had larger tumors or positive lymph nodes, these are some of the results we found. I just want to take a moment to explain these slides because sometimes they can be just a tiny bit confusing. The gold bars are IHC FISH. So you can see in this slide, these are hormone receptor positive, HER2 negative patients by IHC or FISH. The blue bars are the true molecular subtype as measured by blueprint and also measured by mammaprint, giving us a risk assessment. And then, of course, the number of patients are in parentheses. The height of the bars is the PCR rate. So what this graph shows is that in hormone receptor positive, HER2 negative patients, again in the gold bar, they had about a 10% PCR rate to neoadjuvant chemotherapy. But when you break out the true luminal A patients, those patients who have low-risk mammaprints and are luminal subtype by blueprint, they contribute very little to the overall PCR rate. Their PCR rates are below 5%, closer to 2 or 3%. When you take this a step further, again, these are the same hormone receptor positive, HER2 negative patients by IHC and FISH, and you break out the luminal A's and luminal B's now through, and again, these are the same patients being clinically subtyped and truly molecular subtyped. You can see that they get a little bit more contribution from the PCR from the blueprint luminal B's. However, it still doesn't reach the overall 10% rate of PCR. And the interesting thing that we found was about 20% of patients in this group who were estrogen receptor positive, HER2 negative, actually had a basal subtype. So again, this is the group I was alluding to earlier, where although the presence of the estrogen receptor is there by IHC, there's something wrong with the pathway. The estrogen pathway is not functional. And these patients are acting like basal subtypes, even though the estrogen receptor is present. And you can see the majority of the contribution of the PCR rate in these patients comes from these estrogen receptor positive basal subtype patients. And these patients these breast cancers are particularly aggressive. So what about the triple negatives compared to the basal? Well, you can see that in this study, there are 52% more patients classified as basal compared to just triple negative by IHC. And this accounts for patients that were estrogen receptor positive basals, HER2 positive basals. And there were 35 clinical hormone receptor positive patients classified as basal who had a 26% PCR rate, and we see that the blueprint basal patients have a similar chemosensitivity as the triple negative patients. So again, although the triple negative patients respond well to neoadjuvant chemotherapy with higher PCR rates, you'll find more of these patients with really good PCR rates when you measure them by molecular subtype. And you can see that evidenced by the numbers. Even though the bars are essentially the same heights, there were 92 triple negative patients and 140 basal patients. What about clinically HER2 positive patients? Well, in this group, we see that there's about 184 HER2 positive, hormone receptor positive patients who had about an overall PCR rate of 37%. However, about half of these patients were actually luminal subtype by Blueprint. And again, this is consistent with Peru's original data as well, where he identified about 50% of his clinically HER2 positive patients had a luminal subtype. And again, you don't get much of a response from these patients that are luminal to neoadjuvant chemotherapy. However, when you break them out into the truly HER2 dominant subtypes, you can see the PCR rate of these patients skyrockets and goes up fairly high. And I will tell you also, when you add, some of these patients were done initially with just Herceptin because pertuzumab did not come on the market till a little bit later, but when it did, this PCR rate in truly HER2 dominant patients skyrocketed up closer to 80%, 70 to 80%. So what is the impact of subtypes on breast cancer therapy? Overall, Blueprint functionally reclassifies about 23% of breast cancer patients compared with traditional clinical subtyping. The PCR rates show that certain functional molecular subtypes, as opposed to histological subtypes, are more chemosensitive, showing higher PCR rates, certainly in the HER2 dominant and basal subtype patients. Molecular subtyping can improve stratification of the patients in the neoadjuvant setting by reclassifying those patients to a more chemosensitive subtype, which also gives us a lot of prognostic information on these patients, because we know that patients who have a PCR, in these, at least in these two subtypes, will do better long term than patients that do not have a PCR. And again, as I alluded to earlier, when you looked at dual anti-HER2 therapy with pertuzumab and trastuzumab used in true Blueprint HER2 dominant subtypes, the PCR rate jumped up to 76% from about 48%. And even in the HER2 positive luminal subtypes, when you added pertuzumab to that group, the PCR rate went from about 9% up to about 36%. And what that suggests is not that the HER2 pathway is not active in the HER2 positive luminals, it's just not the dominant pathway. But clearly, as evidenced by this jump in PCR rates with the addition of pertuzumab, it really suggests that that HER2 pathway is somewhat active, but that the estrogen pathway is dominant in those HER2 positive luminals. And it really does speak to the importance of accurate and true molecular subtyping over clinical subtyping, again, where you can have some not discordant result in about 20% of patients. And again, in postmenopausal luminal A patients, what we found in the NBREAST trial was that about 68% of those patients would have a response to neoadjuvant hormonal therapy. So it really stratifies a group of patients that don't need chemotherapy but would respond to neoadjuvant hormonal therapy. So just to summarize, understanding breast cancer biology through the use of molecular profiling and molecular subtyping is an important step to optimize risk stratification, treatment selection, and resource utilization. Blueprint has demonstrated through both retrospective and prospective trials long-term prognostic ability and predictive utility in early-stage breast cancer. And functional molecular subtyping with Blueprint further increases diagnostic precision, providing valuable information for both neoadjuvant and adjuvant treatment decisions with regards to chemotherapy or hormonal therapy in patients with breast cancer. So I'm going to turn it over to Bill. Bill Audi is the Chief Medical Officer of Agendia and is kind enough to join us on the phone tonight to present some case studies and be available to answer any questions that I can't answer.
Thank you very much, Dr. Pellicane. This is Bill Audi. I am a breast medical oncologist and Chief Medical Officer for Agendia, as you heard. I apologize for the background noise as I am broadcasting while in transit, so please bear with me for that. My role is to present two case studies and ask for Dr. Pellicane's opinion, given his background and expertise in this type of setting. I also know very well, as I'm sure many listening in know, the importance of the multimodality approach to breast cancer with a close working relationship between medical oncology, surgery, and radiation oncology. So let me review this first case. This is a 58-year-old woman who is postmenopausal and not on hormone replacement therapy, without a family history of breast cancer, who is found to have a fairly large palpable mass in her right breast with no palpable nodes in the axilla. A core biopsy confirms this to be an invasive ductal cancer, with routine pathology profiling identifying this to be strongly ER and PR positive, 90% each, 1+ HER2 positive by immunohistochemistry, with a Ki-67 of 10%. And the patient, despite the large tumor, does desire breast-conserving surgery. So in this case, the patient has already seen a surgeon, and the first surgeon has already advised neoadjuvant chemotherapy with the intent of trying to reduce the size of the tumor to render it more operable with a better cosmetic outcome, and has referred the patient to medical oncology. However, she is also seeking a second opinion from you, Dr. Pellicane. So the question we would like to put to you is, what would be your recommendations upon seeing such a patient?
So this patient in our practice doesn't meet any of the immediate requirements for chemotherapy, that being estrogen receptor negative, HER2 positive, or having a tumor that was greater than 5 centimeters, which in that situation, generally speaking, they would qualify for chemotherapy, especially at 58. So this patient always would get a genomic profiling study. We would certainly send a mammoprint and blueprint on this patient to give us a better idea of the biology of this breast cancer. And again, she fits into that second, one of the second categories I talked about taking a patient who is a mastectomy candidate but wants breast conservation and figuring out a way to turn them into a breast conservation candidate.
Okay, very good. So she goes ahead and does have a genomic assay, which is based upon the core biopsy, of course. So in your experience, Dr. Pellicane, is it safe to assume that the core biopsy is adequate for this kind of analysis?
We've been using mammoprint for quite a while, and even since before it was available on paraffin. So we've been sending core biopsy specimens in fresh tissue for many, many years. So we feel very comfortable making treatment decisions based on core biopsy. And it always gives us adequate analysis. Sometimes if we don't have enough tumor tissue, we might need to send another block. Sometimes we have to do it postoperatively, but we make a lot of neoadjuvant decisions based on these results. So we almost always send it on a core biopsy.
Yes, thank you. I'll point out also that even in the absence of genomic analysis, medical oncologists make decisions based upon core biopsies using just the ER/PR and HER2, of course, routinely. So if a mammoprint is ordered and it came back as a low-risk luminal A patient, what would be your recommendations, Dr. Pellicane, for the therapy of this patient?
This patient would be an ideal candidate for neoadjuvant hormonal therapy. We know from the MINDAC trial that this patient would be a clinically high-risk patient and genomically low-risk patient and would not benefit from the addition of cytotoxic chemotherapy. So we would not offer her chemotherapy. We would offer her hormonal therapy and put her on therapy for anywhere between 6 and 12 months as long as we were getting movement on the tumor and the tumor was getting smaller. Generally, it's hard to see a PCR in neoadjuvant hormonal therapy, but you certainly do see a response that would make the patient more amenable to breast conservation. The other thing to keep in mind is there's a lot of talk now about putting patients on neoadjuvant hormonal therapy and rechecking a Ki-67, but I think what we're not doing in that situation is we're not selecting out the luminal B patients who may have some response to neoadjuvant hormonal therapy but really need cytotoxic chemotherapy. And I think MammaPrint enables us to skip that step with that second biopsy because it's really selecting out these truly low-risk patients that are going to benefit from neoadjuvant hormonal therapy.
Great. Very interesting. Just another question regarding your monitoring then, because you did mention that while on neoadjuvant hormonal therapy, you do monitor the patients. So what is your process for monitoring these patients to confirm they're responding?
So we will usually start them on therapy and see them back in a month. And after a month, we'll remeasure the tumor, usually either on physical exam or generally with ultrasound. As long as the tumor is not getting bigger, we don't expect to see a huge movement in a month, but what we want to make sure is that the tumor is not growing and that it will respond to the hormonal therapy. After a month visit, we usually see them back usually every month or 2 months. Out to the 3 to 6 month period, and then we might see them back in 2 or 3 months. As long as they continue to respond, we keep them on it until they get to a point where surgery is more feasible. Honestly, in some older patients who are too sick for surgery or don't want surgery, this has been very helpful for us to know if they're going to respond to hormonal therapy, and we might keep them on it a little bit longer.
Very good. So the last question on this particular patient is to ask you to speculate what would have happened if this patient had actually proceeded on to neoadjuvant chemotherapy instead.
Well, I don't know that it's speculation as much as it's reality. What generally would happen is the tumor would not respond. It would stay 4 centimeters, and then people would start to panic because they would think the tumor is chemo-resistant, and they would take the patient to surgery, when in fact it's not that the tumor is chemo-resistant, it's that the patient doesn't need chemotherapy, and she's going to do well without it. And we have some patients that back this up, and some patients we had on the NBreast trial, and one or two particularly stick in my mind where they came in with larger tumors. One patient was a little older. She was 70. She had a 7-centimeter breast cancer and got neoadjuvant chemotherapy despite the fact that it was a Luminal A by Blueprint and MammaPrint. But based purely on the size of the tumor, she was offered neoadjuvant chemotherapy. And at surgery, the tumor was still 7 centimeters. Hadn't budged, her lymph nodes were negative, and she is now about 6 years out and doing perfectly fine. So this is real data that these Luminal A patients don't need and don't benefit from chemotherapy, and in the neoadjuvant setting, they don't respond to chemotherapy.
Yes, absolutely. And one could even say, because the Luminal A patients are likely to be quite endocrine sensitive, that giving neoadjuvant chemotherapy is not only helpful, but it is in a way delaying the use of the most effective therapy for this patient besides surgery, which is the endocrine therapy.
Absolutely true.
So let me do a second case. A somewhat younger woman, 47 years old, premenopausal. Again, no family history. She has a mammographically detected mass, 2.5 centimeters, found on yearly screening. And a core biopsy again confirms this to be invasive ductal cancer. The molecular profile by pathology shows ER to be 60% positive, PR 50% positive, HER2 1+ by immunohistochemistry, and Ki67 20%. This is a patient who a prior surgeon has seen and advised that she be taken directly to resection, planning to refer to medical oncology post-operatively, but planning to go to surgery. Just as with the last case, if this patient came to you for a second opinion, what would be your recommendation?
Well, the same thing. We would always send, with this profile, we would always send a MammaPrint and Blueprint preoperatively. And in this situation, the idea would be to know whether the patient was going to need adjuvant chemotherapy or not, and just so we could put a portacath in at the time of her initial operation, just to save her an operation, to expedite things for our medical oncology colleagues. So she absolutely would get mammoprint and blueprint.
Okay, so this patient does get a mammoprint and blueprint, and she comes back high risk, but her molecular profile is basal. So knowing that now, would you recommend neoadjuvant chemotherapy or proceed to resection as the original surgeon planned, followed by adjuvant therapy?
Yeah, it's interesting, and it would be a discussion, but in all likelihood, in Richmond, this patient would get neoadjuvant chemotherapy, and she would get aggressive chemotherapy. So she definitely would get she'd get adriamycin, Cytoxan, and a taxane, and in all likelihood would get carboplatin as well, and she'd be treated as a basal subtype. Having said that, after surgery and after radiation, if she had breast conservation, she'd also be put on an estrogen blocker. We would pay attention to the IHC, even though we don't really think that pathway is active. We would still treat her. But from a chemotherapy perspective, she'd be treated as a basal patient, as a triple negative patient, and get neoadjuvant chemo.
Yes. Yes, that makes a great deal of sense, particularly because we know how important the PCR rate is for prognosis in basal type breast cancers, where achieving a PCR is associated with an excellent prognosis, while not achieving a PCR is often associated with a very poor prognosis, and at least from some of the recent data may suggest the need for further chemotherapy such as capecitabine after surgery. This type of patient you did allude to with this chart that you showed earlier, Dr. Pellicane. This was from the NBreast trial that you were involved with. ER-positive, HER2-negative patients, just as this case was that we just described, showing the PCR rate overall by the gold standard of IHC, but when you use the molecular profiling, you have the luminal patients who clearly have a lower PCR rate, and then you do find in at least 18 to 20% of the time the basal, genomically basal subtype within this ER-positive cohort, very likely to have quite a robust response to neoadjuvant chemotherapy. Now, when this entity was observed, the question was certainly raised as to what was going on biologically that could create a basal subtype which expressed estrogen receptor. And on analysis, it does appear that there is estrogen receptor and estrogen gene mRNA present in these tumors, but that the estrogen receptor itself is simply non-functional due to an abnormality in the way the mRNA was spliced together. We might assume that we could recognize these patients pathologically by low ER protein expression. And from this plot I'm showing you here from the NBreast data, you can see what the range of ER and PR expression was in these ER-positive basals. Each circle represents a patient, and where there are overlapping circles, they become black. Most of them do indeed cluster in the lower ends of the expression range, but I think it's important to point out that these ER-positive basals can have ER expression as high as 100%, and PR, at least in this cohort, as high as 50%. So we cannot assume that we can find them with routine immunohistochemistry. The other point to make, again from the NBreast trial, which you also showed, was that the PCR rate of these ER-positive basals is very similar, if not identical, to the PCR rate of a true triple negative, and therefore tends to warrant a more aggressive type of chemotherapy than most oncologists may have in mind when thinking to treat a high-risk luminal case. So with that, I will conclude the cases. Thank you for your rendering your opinion on these cases, and I will turn things back over to Jessica to provide us with any questions that may have come in from the listeners.
Thank you, Dr. Oddie, and thank you, Dr. Pellicane, for that presentation and the case study review. So we're going to spend some time now answering questions that our audience members have submitted. The first one is, how do you manage HER2 equivocal by IHC patients in your practice?
So in our practice, if we get an equivocal IHC, we would then reflex the FISH. If the FISH came back, obviously if it came back positive, we would treat the patient. If it came back negative, we wouldn't. If it came back in a true equivocal, where she was equivocal by IHC and FISH, then we have a discussion. But generally, I will usually always send a mammoprint and blueprint on those patients and use the molecular subtype to help guide a treatment decision. The majority of those patients, at least in our practice, are going to come back luminal. But every once in a while, you might find one that comes back HER2. But most of them, for the most part, come back as luminal subtypes, and we treat them as such.
Jessica, let me add also that from the Agendia laboratory database, we have recently reviewed the patients whose tumors were sent to the Agendia lab for mammoprint and blueprint with a HER2 equivocal pathology analysis. These patients were then provided with mammoprint and blueprint, and the frequency with which they had the different subtypes was analyzed, and that will actually be reported as a presentation at the upcoming San Antonio Breast Cancer Symposium. And so I would recommend to anyone who is interested in this particular group of patients how genomic profiling may actually assist in the precision management of HER2 equivocal patients. I would recommend that you seek out this abstract from the Agendia database.
Thank you both for that insight. And the next question is, our med-oncs, and particularly our rad-oncs, would be very nervous in this patient, not knowing the past status of her axillary lymph nodes. How would you address that with them?
I'm reading the question. Well, you mean preoperatively? Pre-chemotherapy. So that is really a hot topic, if you will. How to manage the axilla in patients who are getting neoadjuvant chemotherapy. And I will tell you, in our practice, going back probably a year, these patients would all get sentinel lymph node biopsies at the time of portacath insertion prior to neoadjuvant chemotherapy. We have really gotten away from that because it number one, oftentimes doesn't add a lot of information to what we're doing, and number two, the likelihood of finding a positive lymph node in a patient with a clinically negative axilla is again quite low neoadjuvantly. So I understand the angst of the specifically the radiation oncologist, because of all the data, and all the data coming out and the push to do post-mastectomy radiation on these patients if they have one or two positive lymph nodes. But again, in a lot of ways, I think that data is suspect, and we don't knee-jerk into. I'm sure no one really knee-jerks into anything in this business, but we don't look at a patient and say just because they have one positive lymph node, they need post-mastectomy radiation. We really do look at genomic profiling, we look at the risk, and we look at the patient. But again, and in the patient that's going to have a lumpectomy, it oftentimes doesn't change the ultimate therapy because they're going to get radiation anyway. So I hope that answered the question.
Thank you. And the next question is, any prospective data on response rates of MammaPrint low-risk tumors to endocrine therapy?
The paper, I believe we published a paper on this, and it looked at response rates of patients who had luminal A and had neoadjuvant hormonal therapy, and the response rate was about 68%. So about 68% of patients got some clinically significant response to neoadjuvant hormonal therapy, and they were treated anywhere from usually from 6 to 9 months.
Thank you. The next question, what is the differentiation of subtypes in ER-negative, HER2-negative breast cancer?
So the differentiation of subtypes in estrogen receptor negative patients, there's a small group of patients, and Bill, please step in and correct me if this is not correct, but there's a small group of patients that will actually be HER2 positive, high-risk HER2 positive, but that group is very, very small. In the ER negative and HER2 negative patients, you will find again some HER2 positive, HER2 dominant patients. You may even find a luminal subtype, but I think that would be very, very rare. I think really what you're going to find in this group is mostly they're going to be basal subtypes with the occasional HER2 dominant subtype.
Yes, I can add that this certainly is an area of active interest, trying to dissect further the estrogen receptor negative, HER2 negative population that we all refer to as triple negative, but we know that there's diversity within that group, as we've seen published from various sources, including the Vanderbilt group. I think the experience with MammaPrint and Blueprint has been that there is a proportion of these patients who, despite being triple negative, come back luminal. And we believe those are being identified as the most likely androgen receptor positive triple negative subset, which has been identified by several groups. That's a subset of triple negative that does not appear to have as high a response rate with chemotherapy, and is being studied, as I am aware, in research protocols with anti-androgen therapies. But at this point, I don't believe there's any deviation from standard of care therapy that has been supported with any real data. But that's likely to be the answer for that type of patient.
Thank you. This next question is a long one, so I will read it first and then I will push it to the slide area. Given the tumor heterogeneity that not infrequently is encountered in breast carcinomas, don't you think that genomic studies should be performed or at least confirmed on resection specimens? Examining the entire tumor and selecting the most appropriate area might give results that are better representing the biology of the tumor.
Bill, I think I'm going to let you handle that one, since you probably know a lot more about the processing of specimens than I would.
Yes. Well, I think there are a couple of comments to make about this. One is that if a patient is not being considered for neoadjuvant therapy and is going directly to resection, that we would prefer the resection specimen rather than the biopsy, simply because we have more tissue to choose from, to choose what we believe would be the most informative portion of the tumor. Nevertheless, we have performed concordance analyses by sampling different areas of the same tumor and have shown a very high concordance rate with essentially the same MammaPrint result being obtained from different sections. I think part of this question might also relate, though, to the neoadjuvant setting, since that was the topic of today's webinar. And in that case, the dilemma becomes comparing the pretreatment tumor tissue with the residual tumor tissue after neoadjuvant chemotherapy or neoadjuvant endocrine therapy. In those cases, we would not at all be surprised if there had been a change because the therapy has changed the population of the tumor cells that are being analyzed. This is, again, an area of research to study the residual cancer burden remaining after neoadjuvant therapy when there has not been a PCR. Again, the treatment has to have been decided based upon the core, but what you have remaining may look somewhat different because it's resisted the original therapy.
Thank you. And would you add a CDK4/6 inhibitor to neoadjuvant endocrine therapy?
We would not do that as primary treatment. But that would be up to our medical oncologist if they thought there was some benefit to that and the patient was not responding to just standard aromatase inhibitor. And Bill, you have any thought on that?
Yes. Again, that's a topic of clinical research, and there are no data that really support doing this as part of the standard of care, although I think everyone would speculate that there would be a proportion of patients who would have a greater response with the addition of a CDK4/6 inhibitor. But again, that remains to be seen with prospective randomized research. One could also argue that adding this type of targeted therapy may be helpful not only in luminal A breast cancer, but also even in luminal B breast cancer, where we know the PCR rate with chemotherapy is very low, and that may be because of the need to be treated with something else like a targeted therapy. For this, we need more research, however.
Thank you. And how does lymph node status influence your utility of neoadjuvant chemotherapy or genomic testing for these patients?
That's a great question, and that does come up once in a while because, as we know from the MINDAC trial, which looked at genomically low-risk patients with up to 3 positive lymph nodes who did not benefit from chemotherapy. So the question is, if you have a luminal A patient with 1 positive lymph node, do you subject them to neoadjuvant chemotherapy not knowing what their true lymph node status is? So sometimes it gets a little tricky where you're trying to look at the ultrasound, you're trying to count lymph nodes, or you're looking at the MRI to see if you get a feeling that there are more than 3 abnormal lymph nodes, in which case the patient would require cytotoxic chemotherapy regardless of their genomic profile. So it does get a little dicey at times. It might be an indicator to at least to sample the lymph nodes first, and it gets back to that other question about lymph nodes, where the bottom line is if you really feel like the lymph node status is going to change what you do, then you might consider knowing that status prior to treatment, and even segueing off of the neoadjuvant hormonal therapy to regular neoadjuvant chemotherapy. A good for instance, and this has occurred in our practice recently, if you have a patient who has a HER2 dominant breast cancer, or HER2 positive breast cancer, and the treatment the lymph node status is going to change the treatment because their tumor is under 2 centimeters, then it might be worth getting a lymph node status on those patients preoperatively. So you can add pertuzumab, or in the case of a basal cancer, add carboplatin. So if the bottom line is if you think the lymph node status is going to influence your treatment, then you ought to know it. But it's difficult because, again, it's hard to know just from imaging how many lymph nodes are positive, and that takes on greater importance, especially with the MINDAC trial reporting.
Thank you. Any tumor overexpressing HER2 is given chemo. Should we bother with genomic testing for these tumors?
Well, I think at the current time, there's not really enough data to withhold treatment from any HER2 positive patient. And so genomic testing in that subgroup of patients may add very little to the ultimate therapy that patient's going to receive. And again, even if the patient comes back clinically HER2 positive in a luminal subtype, it does not get the patient out of HER2-directed chemotherapy. So that's the long answer. The short answer is there's a lot of research going on in that population because of the incidence of genomically low risk HER2 positive and HER2 dominant subtypes, and how to treat those or maybe de-escalate therapy in that population. But right now there's not really enough data to make any large decisions based on genomic testing in that population.
Just to add to that, I think the only setting in which it may be helpful or affect management decisions would be in those triple positive patients, ER positive and HER2 positive, that were shown by Dr. Pellicane from the NBREST trial, where there's clearly a differential response to neoadjuvant therapy depending on on if they're genomically luminal or genomically HER2 driven. And if the decision to give therapy in the neoadjuvant setting or go directly to surgery is going to be contingent upon how much tumor shrinkage there is, then it's possible that knowing that a patient is luminal in its dominant pathway may suggest that going to surgery first may be preferable to proceeding with chemotherapy when the likelihood of a PCR is considerably lower than if they were HER2 driven. So it might affect the timing of surgery for some physicians, but as Dr. Pellicane says, it would not really affect the choice of therapy or the decision to give chemotherapy.
I would add one point to that also along those lines. If you do know that the patient is HER2 positive and luminal and gets neoadjuvant chemotherapy, because you don't expect a high PCR rate, you expect some PCR rate but not a very high PCR rate, it may help you to kind of dig your heels in a little bit instead of pulling the trigger and going to surgery, because you don't expect the patient to respond that well. So when they don't respond, you're not surprised. And so you end up completing their chemotherapy prior to going to surgery and getting it out of the way and getting their initial therapy complete. So on both ends of the spectrum, it certainly can be helpful.
Thank you to both of you. This next one is more of a comment rather than a question, so I'll read this and then we'll head into our last question after that. The comment is that the PALET study, which is neoadjuvant CDK4/6, will be presented at SABCS in 2018, so coming up in December. That the person wanted everyone to know that. And then the final question for the day is, overall clinical response rate of ER tumors to chemotherapy is greater than 80%, even though PCR is unlikely. Isn't that beneficial?
I have to read that question because I don't know. I think if those patients in that situation are genomically high-risk patients, I mean, it's certainly beneficial. I mean, the end result, again, there's been no survival advantage shown by giving neoadjuvant chemotherapy, and the presence of a PCR is prognostic, but that's all it is. And then there's some thought process that you're just getting your prognostic information sooner than later, or you're getting it where you may not have gotten it at all. if you resected the tumor first. But is a response to chemotherapy, is it beneficial? If the patient needs chemotherapy because they have a luminal B tumor, then I would say getting their chemotherapy without delay is beneficial because of what I had alluded to earlier. We know that a delay in chemotherapy can be harmful to patients. And so I agree with the premise of this question, which is, I think, if you know a patient needs chemotherapy, why not just give it to them preoperatively regardless of what their PCR rate is? But I think knowing the type of tumor it is, knowing the molecular subtype, and knowing the likelihood of a PCR is helpful when you're managing that patient through their chemotherapy and trying to make decisions about who's responding, whether they're responding well or whether they're responding minimally, as opposed to not responding or the tumor is progressing on treatment. And then you're making decisions about whether you should abort chemotherapy and go to surgery. So again, that's a long answer, but yes, it's beneficial, but knowing the subtype and knowing the potential response to chemotherapy is also beneficial.
I would want to add, though, that I'm not entirely sure what type of ER-positive tumors the questioner is referring to when claiming that there's a greater than 80% response rate. I'm not sure that I would assume that higher rate, and in fact, that's the purpose really of genomic analysis, is to get beyond what the presence of the estrogen receptor claims to be telling us. I would even argue that giving chemotherapy to a luminal A tumor is not likely to be beneficial, and we've got outcomes data to show that. And it does, in effect, add toxicity and delay the application of the most effective therapy, which is endocrine therapy. So while I agree one doesn't have to achieve a PCR with an ER-positive cancer to obtain benefit from chemotherapy, I still believe that knowing genomically which ER-positive patients should receive any chemotherapy at all is still the essential question.
Agreed.
Thank you. And thank you, Dr. Pellicane, and thank you, Dr. Adi, for answering all of those questions. Thank you to everyone for participating in our webinar. Please don't forget to fill out our short survey that you see on your consoles. We truly appreciate your feedback. We hope to see you at our next event. Thank you, and this concludes today's webinar.